Следующее сообщение посвящено современным аспектам реанимации пострадавших с сочетанной травмы. Доктор Гандолин Л, отдел ортопедии и травматологии университетского центрального госпиталя Хельсинки, Финляндия. Please.
Hello. This working? Yeah. Okay, dear Chairman, Professor, colleagues, my name is Lauri Gandolin and I'm coming from Helsinki University Hospital, Finland, and I'd like to thank you for the opportunity and nice invitation to come here and speak. And I'd like to congratulate you. I'm still on? Yeah. You on the 25th anniversary as well. So I'd like to spend with you a few minutes on the modern aspects of the resuscitation of the patients with polytrauma. And if we look at the definition of modern, what does it mean? It means that there is something recent, present, and most up-to-date techniques, ideas, and equipment, which is quite nicely in line with the topic of this symposium. So I'd like to focus on the resuscitation, and I'd like to address that actually the resuscitation starts from the accident scene and continues into the ICU. So resuscitation is not something that only happens in your hospital ER, but it starts from the field and it continues from the field to ER, to OR, and to ICU. That's all resuscitation. And I'd like to give you an overview of the chain of the survival, and we're gonna have a quick glances on every links of the chain. So if you look at the link chain of the survival in cardiac arrest, you need to remember that it's not only the post-trauma or post-cardiac arrest care that counts. It's every link of the chain, and same applies to trauma. It's not the stuff we do in OR, not the stuff we do in ER, but it's everything. It's the whole chain. And if we look at the components of the chain of the survival, first we have the dispatch call center receiving the phone call. We have the emergency medical services. We do the resuscitation in ER. We go to CT, do some surgery, maybe some endovascular stuff. We go to ICU, and after that we follow up our patients. And let's have a look on the modern or something new or something recent on every link of the chain. So something new that's coming up regarding to car crashes is so-called e-call system, which is automatic emergency call after car crash. And actually that becomes a mandatory in every new car in EU in 2018. So it means that whenever your car crashes, the car automatically will send the coordinates and the information of the accident to the dispatch center. And it also opens up the voice connection. So if you are conscious and you can talk, the dispatch personnel will hear you and you can talk to them. So this is something new when it comes to dispatch system. And if we look at the emergency medical services, one of the very handy practical thing we have is the online system, meaning that whenever the paramedics are on scene, they have a small computer-like system with them, and what happens is that whenever they fill in something or whenever they monitor or some vital functions which automatically go into the computer sends the information online to the receiving hospital. So basically we see online the vital parameters of the arriving patient. We do see the pulse, we see the blood pressure, we see everything. We see what drugs they've been given, what treatment they've been taking under the route. So this is something very handy and practical. And if we consider the role of EMS, they need to fight, like we in hospital, the EMS need to fight for the reversible causes of the cardiac arrest, and in trauma, it's the tension, pneumo, tamponade, hypoxia, and hypovolemia. And if we look, the list of the things the emergency medical doctors need to do in field, it's huge. So, but in the modern way, the emergency medical doctors, of course, they are capable of doing surgical airways. They give blood cells. In the future, there will be a dry plasma in the ambulances and dry plasma in the helicopters. Even the RIBOA, the aortic balloon, is done in some emergency settings. The emergency doctors are capable of doing thoracostomies and even clamshell thoracotomies for pericardial tamponades. So basically, that's something very new, the clamshell and RIBOA and dry plasma, which is coming up. And this is the resuscitation that starts from the accident scene. So in the ER, the list is huge, and there is not much new there. But something I'd like to address is the training and how do we teach our residents and our colleagues to treat these patients. Of course, there is the ATLS principles, but after the ATLS, there is something new which is called European Trauma Course, and that is a course addressing the team approach. It's not like ATLS addressing you should treat A and B and C. Of course, ETC does that as well, but the main address is on the team approach. How do we do that together? It's a multidisciplinary team of taking care of the patients. Of course, simulation training, like we heard in the previous presentations, is the mandatory thing to train our people. Neuroprotective principles, ultrasound is utilized more and more, even in field, in EMS setting. Massive transfusion protocols, of course. Thromboelastography, like ROTEM or TEG, it's not any new anymore, but still kind of the modern way of monitoring the coagulation status of the patient. And of course, RIBOA, the aortic occlusion balloon. This is something new that is coming up, and I'm sure Dr. Reva will probably discuss that also in the afternoon in his speech. So what about the CT? After the resuscitation, we need to scan the patient. Is there anything new? Yes, there is new. New thing is, for example, is the sliding gantry CT. So basically, whenever your patient comes in, you put the patient on the table and you don't move the patient. The scanner comes to the patient, scans the patient, and scanner goes away. So this is the sliding gantry system, and of course, in addition to the scanning, you need to make your scanning protocols. The program, how the scanner is scanning your patient, you need to develop that. And in the modern way, so-called split bolus technique gives you a full body CT angio with venous contrast as well, venous enhancement as well. And simulation training, it's not always easy to take the patient to CT. So basically you need to train that. You need to train and train and train. And of course you have these kind of suits. You have everything there. You have the scanner, you have the table to do the resuscitation, and you can do the surgery and endovascular stuff in that room. And that concept is called Raptor. And this is something new also. So basically you put everything into the one room. In a one room you have possibility to do the resuscitation, possibility to do angiography, you can do operative repair, and you have your CT there. So in a recent way, the ambulance takes the patient to ER, and you take the patient to CT from ER. But in the Raptor philosophy, you skip the ER, you skip the CT, you go directly into your Raptor suit, which has everything. So you do the resuscitation, you do CT angio, you do your endovascular treatment, and you do your open surgery. And after that, the patient goes to ICU. So it's a one-door policy. One room serves everything. What about the emergency surgery? Is there anything new there? Not much. Not much. Yesterday we were talking about the challenge how to maintain the sufficient level of expertise for open surgery, because everything is coming non-operative and interventional nowadays. And you need to train, and you have different concept courses like definitive surgical trauma care, you have ATOM course and other courses. And one of the most important things is to do a cadaver training and also living tissue training on pigs, animals. You need to go to the places where you see a lot of trauma, and also you need to train your people back in your hospital. Imagine the case you need to take the bleeding patient into the OR. Is it easy to start? You are anxiously waiting. Why aren't they ready? What's happening? What's taking so long? I want to cut now. Cut. I can't cut because they are doing something. If you train that, you can decrease the time from the door to cut very short. But you need to train that with your people, and you need to train that systematically. What about the ICU period? Is there anything new? Yeah, ECMO is coming to trauma, and we heard a very nice presentation on ECMO, and it's coming to trauma. And in addition to ventilatory and hemodynamic support, please remember that ECMO is excellent for warming up the patient. You have a coagulopathic cold patient with hyperkalemia and very acidotic. Warm up the patient with ECMO. That's something new. Consider that. And also, well, what about the decompressive craniectomy? This is something still not proven if it's beneficial or not. But at least it's something new. You need to consider if you should be doing decompressive craniotomies for your patients, because the main killer in blunt trauma is brain injury. Penetrating trauma, it's bleeding, but in blunt trauma, it's a brain injury. And of course, after you have managed to keep your patient alive and the patient is discharged, you need to follow up the patients. You need to start rehabilitation, but in addition to the rehabilitation, you need to register the data of your patients. You need to have very exact data on your trauma patients to be able to compare your results to other hospitals, to be able to see how does the things you do in your hospital, how does it influence on the results. For example, if you start using Reboa, and you don't monitor how it was before Reboa, after Reboa, you can't say if it's good or bad. So you need to have very precise trauma registries to be able to do that. So in summary, saving lives, it starts from the accident scene and it continues down to the ICU. The chain of survival is something that you need to be responsible of. It's not good that the ambulance guys, the EMS is doing something and they are doing and developing things. You are doing something in your ER, guys in OR and ICU are doing something. You need to sit down and plan the chain to be very fluent. And you need to plan it together with all the guys. The training and the multidisciplinary training, you need to involve your nurses, you need to involve your technicians, anesthesiologists, surgeons into the multidisciplinary trainings. And you need to have the continuous assessments, you need to have the trauma registry to be able to do that. So train hard, fight easy. Thank you.
Большое спасибо за интересный доклад. Уважаемые коллеги, мы завершаем научную часть пленарного заседания. И сейчас по расписанию у нас в 13 часов